Very Hello, everybody. Please, we are waiting for some people to join, a certain number of people so that we can start our conversation. So please, let's be patient and wait for some number of people to join us. Thank you.
Yes, good evening, everyone. Thank you for joining for today's session. I can see the attendance is not that bad, but we are still expecting others to join, but we can now start. Our speaker today is midwife from Ghana. Yeah, and she's called midwife Adzo. She's a midwife in Ghana. She also have a YouTube channel called midwife Azo, and an Instagram account with the same name. Today we are going to learn about antenatal care and be prepared to learn more, ask questions, and interact. Thank you so much. Welcome our speaker.
Thank you so much, Mercy, for the introduction. So please, how are we doing? I hope we had a good day, and I hope all is well. Yesterday, Takila, I think that's the president, she did a very beautiful presentation on about female genital mutilation. That was very beautiful. How has the program been so far? I would want some of us to share our experiences with us, please. So please just unmute and share your experiences with us. Please, I'm waiting for at least 3 people, at least. Can I share my slide, please?
You can share your slides.
Okay, so please, can you see me? Can you see my face? And please, can you see my slide too?
Yes, you can see your face, you can see your slides.
I'm still very interested in some people telling us at least how their day has been. We are going to have a conversation, so I would want us to make it very, very interactive. So please just tell me how your day has been. At least 3 people, just unmute and share how your day has been with us, please. Hello, please talk. I'm with you. I want us to have a conversation. This is not like presentation, it's a conversation, okay? So please talk. I'm waiting, no. So at least 2 people, from 3 now is 2. Just share how your day has been with us. No one is willing to talk. Okay, then let's move along, okay? So we are talking about antenatal, okay? Introduction to antenatal care. Please. Please, I'm back. Sorry about that. I needed help with something, so Okay, so we are talking about introduction to antenatal care. It's a conversation, okay? So feel free, if you have any contribution, you have anything you want us to know about, feel free and share with us, okay? So what do you think? Before then, introduction to everything is very, very important. How you are being introduced would determine how you will continue doing it. How you are being introduced will determine if you would even understand what it's about, okay? So introduction to everything is very, very important. We'll be talking about our objectives for today's meeting. So objectives, that is what we will learn, okay? So some of the things we'll be talking about are what antenatal care is, why antenatal care, that's the reason why we go for antenatal care. We'll be talking about some routine antenatal visit schedules and some activities that are done with the rationales. We'll be talking about some effects, that's benefits, but good effects, okay, of antenatal care. We'll be talking about focused antenatal care, its aims and benefits. I think I talk quite a bit fast, but I'm trying to really work on it. So if you feel I'm moving a bit fast, please draw my attention so that I come back a little. But I'm trying so hard not to go too fast. Now, if we don't mind, can someone still share with us what antenatal care is? Like what you think antenatal care is? What do you think antenatal care is? Can someone please share with us?
Hello.
Hello, we can hear you. Please talk.
I think antenatal care is for a woman from the time of conception, from when the conception was confirmed until the onset of the labor.
Okay, that's beautiful. Please, who has another contribution? Any other contribution or? Yes. Okay, so as our our colleague said, it's so true, okay? I have 3 definitions for antenatal here, okay? The first one says that it is the care given to a pregnant woman from the time conception is confirmed until the beginning of labor. So it means that the time you realize you are pregnant, your antenatal care starts from that time. If it is 1 week, if it is 2 weeks, the time you did your pregnancy test and you realize that it was a positive test, antenatal care is supposed to start from that time, okay? That definition is for Marshall and Wayno, which is a textbook, okay? 2014 edition. Now, the second definition says that antenatal care is the health care and education given during pregnancy. That's from the Reproductive Child Health Department Annual Report, the 2010 Annual Report. Our final definition, which is very comprehensive, says that antenatal is the specialized care that is given to pregnant women from the time conception is confirmed until the beginning of labor in order to maintain a state of good health of the woman and to improve her chances of delivering a healthy infant at term. So this is very comprehensive, okay? As we are saying that you start antenatal from the time you realize you are pregnant, you've missed your menses, and you've done a pregnancy test, which is positive, okay? So the time labor sets in, this has even given us one of the aims that we want to have a healthy mother and a healthy baby, which is your objective as barrier breakers, okay? So term or Like when do you think mommy is ready to have baby? That's what we are calling term, okay? And we are saying term is 38 to 40 weeks. Now, some people give birth earlier, okay? Some people give birth to 37, give birth at 37 weeks, and they still have healthy babies, okay? But term is from 38 to 40 weeks. Now, why antenatal care? Why do we think we go for antenatal care? Or why do we think we should learn about antenatal care? Can anyone, I'm still coming to us again. Can anyone share with us what they think should be the reason why we go for antenatal care? Anyone available, please? Hello.
Okay, like the definitions have stated, to improve the chance of delivering a healthy baby. So antenatal care is important because we want to deliver a healthy infant.
Okay, thank you so much. Now let's move to what's
Hello.
on the slide. So, hello.
Hello. So I also think that antenatal care is also important to help us detect and prevent any complication such as hypertension in pregnancy, preeclampsia, and all that. So if you're able to start the antenatal, if you're able to attend antenatal clinic, if there is anything that's going to pose a risk for you, the mother or the baby, it will be detected. But if you are not attending, nobody will know what's happening with you or your baby. Thank you.
Thank you so much for the contribution. So as I said earlier, we are having a conversation. So the slides are just leading a conversation, okay? So the first aim here is, the aim of antenatal is to monitor the progress of pregnancy to optimize maternal and fetal health. Okay, we want the mother and the baby to have good health during the time of pregnancy. That's why we are monitoring. So as the last contribution, like the lady that gave the last contribution, she talked about how that if you are not coming, do not be able to identify any problem or challenge you are likely to have, okay? So one of the aims of antenatal is to monitor the growth of the baby and see if the mother is also in good health. The second one says to monitor and maintain the physical, mental, social health of the mother and baby by providing education to the pregnant woman. We are all here because we want to get a certain knowledge. Education is empowerment, okay? Anything you are educated about, you are empowered to do. So if pregnant women are educated, they are able to know what to expect during pregnancy and the things that are abnormal during pregnancy. So antenatal helps to promote their physical health. When they come, you look at them and you're able to know, okay, this woman needs this education. This woman needs that. Mentally, most pregnant women have lots of things going through their minds. So it's during antenatal that you need to, either the care provider needs to probe further to be able to know what's really on their minds. And the pregnant women too, or clients, have to open up and tell their care providers their concern so that both sides would have their aims met, okay? Now the third one says to detect and treat medical, surgical, or obstetric conditions during pregnancy. This is big because there are lots of conditions that could come up during pregnancy, like hypertension, diabetes, surgical conditions. If someone has a previous C-section and the person is pregnant again, you are, by virtue of you doing your physical examination, you see that, okay, this person, we can't let her go through, maybe we can't let her go through labor for long. If she's not progressing, let's allow her to go for another C-section. And obstetric conditions are conditions that are related to pregnancy, okay? It could be maybe the mother is bleeding before, like, you know, you're pregnant, you're not supposed to bleed, right? So if the mother is bleeding, it's an obstetric condition during pregnancy. If the baby has any abnormality, it's an obstetric condition. So we are able to detect all of that during antenatal care. Then the fourth point says that pregnant women are educated on what to expect when they go into labor. This is so important because most people go into labor not knowing what to expect. They are just pregnant, and when they are in labor, they just go. But when someone goes to antenatal as the person is supposed to, the person is well informed about what to expect when they go into labor. The final point says, to establish a trusting relationship between the pregnant woman, her family, and care providers. You know, now, the antenatal care we are given, or we are supposed to give, or we are supposed to receive, is supposed to be one that would leave the family in a place that they don't have a choice than to trust their care provider. So this morning, let me share something with you that would like help you understand this more as a result of why we do antenatal. I think, okay, did I really introduce myself well? I think Mercy did. It just came to my mind that I didn't really introduce myself well because of the example I'm about to give. Okay, so I'm midwife Ajo, okay. My name is Jomeko Ajo Comfort. Pardon me, but I would have to do it here, okay? And I do this on Facebook. I'm saying this because of the example I'm about to give, okay? So a client sent me a message this morning. This person found my number on Facebook, has been following, we've been having conversations. Then today, she sent me a message that, oh, midwife, I am afraid about labor. I am afraid that what if I lose my baby? What if my baby doesn't come out healthy? What if I have any complications? You know, people get to a place where they could talk to you if only they can trust you. And that is the place of establishing trusting relationship between you and your pregnant women, okay? Or anyone, because we are people that have the knowledge, we should be able to open ourselves up so that anyone that comes around us would be able to be informed. Now, how did I answer or how did I help this lady? I told her that, you know, she says she's afraid labor is painful. She might not have her baby. She's afraid she could get episiotomy. She's afraid. So I told her that, okay, so, you know, fears happen as a result of things you've exposed yourself to. And I am teaching you what to expect in labor. All that I've taught you is all you expect. So if you are with someone that's telling you something negative, try and decide on what you really want to hear. And that's so key during pregnancy. So I trust that example has helped us to know the place of establishing trusting relationship between the people around us, especially our clients. Now let's move to our next slide. Our next slide, before then, I was thinking about how then we could achieve the aims we've talked about, okay? And it still boils back to establishing, like you should be critical and evaluate all that you talk to your client about, okay? You should really observe their physical appearance. You observe them while they talk, what they say. And as we will be talking about some of the things we do at Antenatal, you'll be helped to know what really the midwife expects from the client, and the client also expects from the midwife, okay? So then this slide is talking about the antenatal routine visits. I think, what was it, 2 weeks ago, a client Hello, are we following, please? Hello.
Yes, please, we are following.
Yes,
Please, can I continue?
Yes.
Okay, so we are going to talk about routine visit schedule. Okay, so it is recommended that all healthy pregnant women should have at least 4 antenatal visits. Okay, it's at least, so you can have more than 4 visits. Okay, but if you are healthy, you realize that the schedules they give you would be at least 4 times. The first time you come to the antenatal clinic is called the booking visit. So when a pregnant woman comes in, it's a booking visit. Lots of questions will be asked, which we'll be going into soon, okay? Now, the booking visit is to confirm the pregnancy, to evaluate if the woman is in good health or has any potential risk condition. This is done through the scans, the tests, and all the other things we'll be talking about in our next slides. Okay, so just stay connected. Now, if there are any complications found on the pregnant woman or after the test results are out, that woman would visit more than 4 times, okay? But if the woman has all the labs, like all the lab results are well, everything is fine, then the woman would have this 4 visits I'm about to show to you right now. Now, the first visit should be between, like before 14 weeks. Now, before we get here, I want to just avert our minds to the trimesters, okay? During pregnancy, we classify pregnancy into 3 trimesters. The first trimester is 1 to 12 weeks. The second trimester is 13 to 26 weeks. And the third trimester is 27 weeks till you give birth, okay? Now, when you come for the first visit, we want you to come before you are 14 weeks. And that is the booking visit. Then the next visit would be scheduled between 16 to 20 weeks. The second visit would be between 24 to 28 weeks. The third visit, 28 to 32 weeks. And the fourth visit, 36 weeks. Now, maybe you've come for your 36 weeks visit, okay? And you went home and 2 days later you are ill. You should still come back to the hospital. So that's the note beneath it, that every pregnant woman should be counseled that if it's not yet time for their routine visit, but they are unwell, they shouldn't stay at home with their challenges. They should come so that they would be helped, okay? Okay. Now, we are going to talk about some routine activities that is done at antenatal, okay? The first one is registration and comprehensive history taking. The second one is general examination. Third one, obstetric examination, laboratory examinations, investigations. Then they do treatment and prevention and health education. I'll be talking about them one after the other so that we get a fair idea of what really they entail. Before this, if someone comes to you, as I said in our introduction to everything is very important, okay? So if someone comes, how you receive the person and even how the person is received is what would determine how the person would react towards you, okay? So mostly clients complain about their care providers. Care providers also complain about their clients because it's a two-way affair. One person has to be nice to the other, and the other too has to be nice to the friend, okay? So first impressions are very important. First impressions, when people meet you, how do they perceive you to be? That really shows how they'll receive from you or the image they'll send away after they've left the clinic. So now talking about registration and comprehensive history taking, the pregnant woman is asked lots of questions, okay? So the first one, we want to know the social history of the woman. So if you're a pregnant woman or you are planning to get pregnant, you'll be asked all of this, okay? Your name, your age, address, occupation. You know, some people, like someone will ask, why all this? Why do they want to know my occupation? Why do they want to know where I stay? Why do they want to know my age? Because when you know someone's age and the person is pregnant, you can be able to tell some kind of things that are likely to happen to the person during the person's pregnancy, okay? And the occupation, when we know your occupation, we can be able to tell if you could afford a certain kind of medication or you would want another kind of medication, okay? Even your occupation would help us know the language we should speak to you, if it should be your local dialect or it should be English language. So how you interrogate with the person and the answers the person gives you helps you to know how to move on during your subsequent time with the person, okay? So that's why we take the social history. Now, talking about medical and surgical histories, it's very important we ask the people, the clients that come to us, or if we are clients, if we are asked, let's openly tell the truth. So I had this client who has had a C-section before and never told the care provider she's had a C-section. You know, they did physical examination, okay, but you know, now the C-section cuts are like, it's so thin that if it heals well, you could hardly see it. And this lady she had come, they had assessed her, and they thought she had not had a C-section before. And she never voiced it out because she said she wants to experience normal delivery to like spontaneous vaginal delivery. She said she wants to have both experience. So she didn't tell the care provider that she's had a C-section before. Now, her labor wasn't progressing well. The nurse was still probing, but like, why? Like, your labor is not progressing well. Are you sure you've not? Although a lot of things can affect labor, okay. But if someone has had a previous C-section before, depending on how long it's been, the interval, we will not want the person to go through vaginal delivery. So this person hid all the information, especially her surgical history, from her nurse. And so actually it was a colleague that was sharing the story with me. She said she persisted that she would refer the case. The lady was pleading. So she referred her to a bigger facility. And when she got there, they had to do another C-section for her. That was when they realized that she was a past, like she's ever had a previous C-section. So if that colleague had kept her at her facility, other things could have happened. So it's very, very important that we probe till they tell us if they've ever had any cesarean section, myomectomy, any surgery before, okay? All the physical examination, if the scars are prominent, you could see it, okay? Now, if the client has any allergies as a result of anything they don't like, or anything that they react to, let them tell us so that it informs the kind of medications you give them, okay? If the person is on any medication, the client has to tell the midwife that I am on this medication, I take this medication, this has been happening to me, okay? Now let's go to family history. Family history on anything, any health condition, if it's diabetes, if it's hypertension, if it's mental illness, anything about family, okay? If it's twin gestation, are there triplets in their families? Like, do they just get pregnant and they have triplets, you want to just be informed about their family history. Okay. Now we would also take their obstetric history. Obstetric history is just about their pregnancies, okay? In this context, is their pregnancies, either past and about this present pregnancy. Now, including abortions, either spontaneous or the ones that were terminated at the hospital, or the ones that either is spontaneous or the ones that they was terminated at the hospital, okay? So how will you ask this question? Some people will never tell you they've aborted. So you ask them, how many pregnancies have they had before? How many do they have at home? How many children do they have at home? Then you ask them, oh, have they lost any pregnancy before? So don't say abortion, because most people don't resonate with the word abortion. They don't want to be associated with abortion. Maybe some people would want miscarriage than, like, they want to be asked, oh, have you had a miscarriage before, than have you aborted before? So when you put it in that way, they'll be able to freely open up to you, okay? Now for the present pregnancy, we want to know how, like when they missed their period, how that will lead us to our next point, okay? Which is their menstrual history. The menstrual history, we want to know their last menstrual period. We want to know that's when they missed their period. Then would also want to know their contraceptive history. If they are taking any contraception, they've taken any contraceptive before, okay? If they've done either IUD, implant, have they taken the pills before? You just want to be informed about them because they are your clients, okay? I think someone wrote something here. Let me try and read it and let's come back. The person says, talking of occupation, you said you can talk to them according to their occupation. Is it really fair? I think everyone should be treated. Okay, so what I meant was that, you know, when you meet someone that is learned, you can freely flow with the person with the English language, okay? Someone would want to be educated, or like would want the conversation to continue in his or her local dialect, like her local dialect, okay? If you know someone's occupation, it gives you a fair idea of, okay, can this person, that doesn't mean you are being partial. We are treating everyone equally, but we want to meet everyone at their point of need. Okay, please, Alice, please, have I made some sense? Are you okay with that? If you are not clear, are you okay now?
Yes, yes.
Okay, thank you so much for that. Thank you so much. Now, so that's about the history taken, okay? So for the first time, the woman will feel, why are they bothering me with all this? But they are very important. It's very important we take all of this. Now, if anyone has any other question up to this point, please ask before we continue. Please, can I continue? Hello?
Yes, you can continue. Not see any question on the chat.
Please, what did you say? Which chat?
I think you can just continue. I can't see any question on the chat, except the one that you have already replied.
Okay, thank you. Okay, so now we've got into general examination, okay? General examination would entail physical and any other thing we'll be talking about here, okay? So when anyone comes to us, whether they are pregnant, they are not pregnant, we check their vital signs, okay? Which is their temperature, their pulse, respiration, and blood pressure, okay? All of them has reasons why we do it. For temperature, we want to know if you are warm or you are cold. And you know, the normal temperature is supposed to be between 36.2 to 37.2, okay? So if anyone has a higher temperature, the person should be asked to clean herself, drink enough water. If you have para, you can give the person so that like at that time, we can be able to work on the person's temperature, okay? And lots of things can make someone's temperature go up, okay? Now for the pulse, we want to check the pulse to know how the heart is beating. We want to know if like some people, when they come to the hospital, their heart beats fast, very fast, and it affects their blood pressure too, okay? So the normal pulse for an adult is supposed to be from 60 to 100 is not bad. And we are supposed to keep an eye on that's why their name is vital signs, okay? For respiration, we are checking the respiration to know how the person is able to take in room air, okay? The normal respiration for a normal person should be between 16 to 20, some people 22, it's fine, okay? For blood pressure, which is very important, especially for pregnant women, is because some people could have gestational hypertension, okay? So the normal blood pressure is supposed to be for the systolic, so it's systolic and diastolic. It's supposed to be between, let's say 120. So let me talk about the abnormal so that we can use that to know the normal, okay? So the abnormal is any temperature, any blood pressure that's above 140/90 is abnormal, okay? So if it is 130, 80, 120, 70, it's normal. But if it's above 140/90, it is abnormal, okay? Now we want to check the height and the weight of the woman. When we check the weight, especially for the first time she's come to the clinic, we want to use that as a standard, okay? When we know her first weight, when she comes for the next time, we check to see, oh, okay, she's made progress, okay? It means that like she's gone up a little, because during pregnancy, there's a little increase in weight, okay? Most of them really increase, some of them just the gradual increase, which is good, okay? Which shows that, okay, baby is growing well because your weight, baby is now in you. So your weight is your weight plus baby's weight now. Then the height is mostly very constant. So we check it only once when they come. Now we are checking the gait or the gaits because we want to know if the client has any deformity, okay? Someone could have one hand not there. So someone could have one leg, an issue with one of their legs. It would help us to know how to help the person when the person comes for the next antenatal clinic, okay, a visit. Now the head to toe examination, which is very important. So we check the head. There are a lot of things we check, okay? We check the head, we check the eyes, we pull it down a little to check if the person is anemic. We check every part of the body, okay? Then when we get to the abdomen, we do abdominal examination, which we'll get to when in one of our slides, okay? So there's head to toe examination that is done for every pregnant woman that comes for the clinic. Now, obstetric examination, so this is what I wanted to talk about. So after we've done the head to toe examination, we would bore or circle it down to obstetric examination, okay? That's especially on the abdomen, okay? We want to inspect all the examinations. Although we are inspecting, when we get to the abdomen, we take a more critical look on the abdomen, okay? We look at the abdomen, we want to see if there are any stretch marks, if there's any line, especially at the symphysis, like the lower part, to see if they've had a C-section before, if they've had any surgery before. So when you see any surgical incision mark, you ask, oh, so have you had any surgical procedure before? So while you do all of this, we engage them in conversation, okay? so that they feel at home. They know that, okay, this person really is concerned about me. Okay, now we would want to palpate, we would want to touch the abdomen. Now, before we touch, we want to rub our hands on each other. You know, when you do that, it makes your hand a bit warm so that when you touch the client doesn't feel that coldness of your hand, okay? So you rub your hands around on the abdomen, that's palpation. You want to check for, if the abdomen is getting a bit bigger, you can be able to check the presentation, can be able to check the lie and other things, okay? Now we do auscultation. Auscultation is just to hear sounds, okay? So they want to hear the heart sounds, the lung sounds, okay? Now we measure the sphinctophalangeal height, which is measuring from, so we want to check if the abdomen starts getting bigger as pregnancy advances. You know, some people, they are around 30 weeks, from 16 weeks to above, that's when the abdomen start getting bigger, okay? But some people, even 18 weeks, they still have a small, it's as though their abdomen is not coming, like it's not getting bigger, okay? Now we measure this, the sphinctophalangeal height from 20 weeks, because by then we believe that the uterus would have come up a little so that it could be measured, okay? We are doing that so that we can know that his baby is growing well. We want to know if you are likely to have a big baby, or if the fluid, maybe the amniotic fluid is too much. All of that, like measuring the sphinctophalangeal height, gives you an idea on that, okay? I can see one chart here. Oh, attendance list, okay. So that's one of some of the reasons why we do the sphinctophalangeal height monitor, measurement, okay? And from that time, from the 20th week, anytime you come, it will be done for you so that we know how you are advancing in pregnancy. Okay, now we've gotten to laboratory investigations. For the first visit, which is the booking visit, you are given, pregnant women are given a tall list of labs to run, okay? Now the first, so they'll take lots of blood samples. There are a lot of things we want to know, okay? We want to check your HB, okay? When your HB is checked, that's your hemoglobin level. Okay, we want to know if, okay, the normal HB in pregnancy, you are supposed to have HB of 11.0 grams per deciliter and above, okay? So below 11 grams per deciliter means that either you are becoming anemic, you are either having mild or severe anemia, okay? So we do that, then we know what we can do to quickly help you boost your HB. Then we also check their sickling status. When we check that, we tend to know, okay, if baby is likely to also have such, you know, sickling is very important. We need to know your sickling status so that we know how to manage you even when you are during your pregnancy, because most sickle cell patients have so much pain. So if you are pregnant with sickle cell, if it's SS especially, they are given special treatments, like they have to be given good care, taught what to do if the pain arises, especially the vaso-occlusive pain, okay? So that's why we do the sickle testing, okay, sickle cell status test. Now we do the resource factor. Resource factor is so interesting that we have to do it, okay? So, you know, resource factor is a protein in the blood which helps it, okay? It helps the blood in so many ways, okay? If someone is resource negative, if a pregnant woman is resource negative and the partner is also resource negative, they are likely to have a child that will be resource negative, okay? But if the woman is resource negative and the partner is resource positive, it's likely that they will have a resource positive baby. Okay, let me just make it short. Anyone that is resource negative would have to be given anti-D, okay? Anti-D is a vaccine, it's an hemoglobin. It's a vaccine that's given, okay? What it does is that, you know, with resource factor, people that have resource negative end up having, if they give birth, or maybe they miscarry. Okay, so let me talk about giving birth first. If they give birth to their first child, fortunately, their first child could sail through, but if the anti-D has not been given, their second pregnancy would be a bit difficult, okay? Because there would have been, the blood would build in, how will I say it? The blood will start fighting that baby, okay? Because the resource factors are in the blood, okay? So if someone is resource negative, the person has to be given anti-D during pregnancy. That's around 32 weeks and 72 hours after baby is given birth to, okay? So that it doesn't fight the next pregnancies when she gets pregnant again. That's why most people, when they got pregnant and they miscarried, like they had a miscarriage, okay, they didn't know if they are resource negative or resource positive. Any other pregnancy, if it's resource negative, any other pregnancy would be lost because antibodies have been built in the body already. So resource factor is very, very important, and we should keep an eye on anyone that is resource negative. Now we do VDRL test to be able to rule out syphilis. Okay, syphilis is a sexually transmitted infection. So when we do it, we are able to know that, okay, this client has syphilis. We give medications. We talk to the person on how to care for herself during her pregnancy, okay? Then we also do HIV test, which is very important because we want to prevent mother-to-child transmission. We do hepatitis B test, which is also sexually transmitted. HIV too is sexually transmitted, okay? So we do all of those tests so that we know how to really care for our woman during her pregnancy and when the person is due for delivery. One other very important test that is done is GSPD. So GSPD is glucose phosphate hydrogenase, okay? What GSPD does is that, so GSPD is also an enzyme in the body, in the blood, okay? If the people are deficient of, if any pregnant woman is GSPD deficient, it means that the person shouldn't accept some things, okay? Like some sulfur medications, anti-malaria medications. There are some foods that people with GSPD are not supposed to eat, okay? Now we have partial defect and we have full defect of GSPD. So it's very important we keep an eye on all these tests when the pregnant women do it. And if you're a pregnant woman and you do this test, you should be able to ask questions. Oh, so what is the way forward with this? How will I go about this? Then all the help you need would be given to you, okay? Now the last test we do is grouping. The reason why I wrote only grouping without writing cross-matching is because we are not going to transfuse now, okay? The grouping, we are doing it to know the person's blood group so that when we know the blood group, we know that, okay, if the person needs blood, this is the blood group we would take the blood from. So it's very important we do all of these tests. Now, if you have any question on the blood tests, please ask. So I've opened the floor now. Anyone having questions on the blood tests, please ask your questions. Hello. Hello, everyone. Please, are you with me?
Yes. Hello.
So any question on the blood group, the blood tests, please? Or I should go ahead. Okay, someone says I didn't get the GCSPD word, so let me talk about GCSPD. So GCSPD, as I said earlier, is glucose 6-phosphate hydrogenase. Okay, so what happens, as I said earlier, was that so we have full defect of GCSPD, we have partial defect, okay. We need to know your GCSPD status because some people or everyone, depending if it's full defect, you are not supposed to take sulfur medications, you're not supposed to take anti-malaria drugs, you're not supposed to eat certain kind of foods, okay? Now, if this is not known, you would realize that you will always be anemic. So let me use this example to maybe explain. So one of my lecturers, okay, shared this with us. She said when she was young, she's always been falling sick. So the parents thought she had sickle cell. They went to the hospital and they said, your daughter is not sickle, like she's not having sickle cell. So they were wondering what really could cause it till they did GCSPD. You know, we wait till it's time for pregnancy before we do GCSPD. And this was a girl that was like, she said she was young then. So no one even thought of doing GCSPD test for her. So one doctor just said, oh, let's try GCSPD. They did and they realized that she was GCSPD full defect. Please excuse me, just drink some water and come. So they did the GCSPD test and they realized that she was full defect GCSPD. So it means she was reacting to something. So people that have full defect and partial defect mostly become anemic as soon as possible, like because they don't know what they should avoid, they end up engaging in them. Have you seen? So they take things that have sulfur, they take things that they take anti-malaria medications, which are not good for them. So please, that about GCSPD. It helps the healthcare professional or provider to know what to avoid for each client, okay? If we know your status, we know, oh, okay, this is not good for you. The other is not good for you. So we know how to really be with you or care for you during your time of pregnancy. So please, any other question? Are we clear with the GCSPD now, please?
I have a question.
Sure, please ask.
So the sickling status,
Yes.
is it something that you do in your country particularly? Is it something that you do on during when a mother visits, or it only happens when the mother is actually a known sickler?
Okay, in our country, we do it to anyone that comes for the booking visit. Okay, so these are tests we do for everyone that comes for the booking visit. And we take record in our antenatal book. How is it done at your end, please? Could you please share with us?
For Kenya particularly, we do
please.
the other tests like the HB, RESAS, the VDRL test, the HIV, and the blood grouping, but rarely, like unless, I don't know, for the cases of the various hospitals I've been to, we never actually do the sickling status unless the mother is a known sickler. Like, I don't know, maybe someone has a different view on that. Because I don't know, maybe it's because it's expensive, or I don't know, maybe it's different for Kenya and Ghana. I'm really not sure.
I know, right? maybe it's the hospitals you visited. I believe some hospitals would go all out for that, I believe. So please, can I go ahead? Can we continue, please?
Yes.
Okay, so we take the sample of the client's stool, okay? Want to check if there's any, this is rarely done because no one wants to smell someone's stool, but it's supposed to be done, okay? You're supposed to take the stool sample to be able to know if there's any abnormality in the stool, okay? I remember when we were at school, we were taught some characteristics of a good stool. Would you imagine? And some of the things we were taught was that it should be cylindrical. They said it should be golden brown in color, which was so interesting. So these are some of the things they look out for, okay? Then for the urine, we want to check for glucose, protein. That is, we use the test strip, okay? But sometimes we take it to the lab itself, okay? Where they can check if the urine is hazy, if there are leukocytes or any blood or anything in the urine, they're able to find it when they do their labs at the lab itself. But when we use the dipstick to do it, the urine strip to do it, we're able to check only the protein and glucose, okay? And you know, these are very important parameters we need to check, okay? When you check a client's urine and it has proteins, it should draw your mind to, oh, okay, let me check her, let me take closer look to let me check her blood pressure again and see if is her blood pressure normal. Then your mind is getting to, oh, could it be preeclampsia? Then if you check the glucose and the urine and there's glucose in it, you are wondering, could it be diabetes? What is really happening to her? Maybe there's glucose in the urine, she's sweating profusely, and she's so unhelped, so disorganized, and your mind will start going through, you start trying to put your thoughts together on what really could be happening to this woman, okay? Then it would help you to best give the person the attention and care they need. Now we do ultrasound scan to rule out extrauterine gestation. You know, some people have ectopic gestation. Ectopic gestation is extrauterine. So extrauterine is just anything outside the uterus, okay? So if we realize that we do a scan, realize, oh, it's an ectopic gestation, then we are informed, we quickly observe to see if we can do medical termination. We can use medical means to help work on it. And if medical means will not be able to work, maybe the ectopic has already ruptured, then we quickly go for a surgery, okay? So ultrasound scan is done to determine the number of weeks the pregnant woman has gone through, so far, the number of weeks. It helps us to detect abnormalities in the baby, the placenta abnormalities. It helps us to determine a lot of things, the amniotic fluid quantity. It helps us to determine the sex of the baby. It helps us to determine another thing, which is the expected date of delivery, okay? So it's very important we do ultrasound scan we write it, we request it for them, okay, for them to do it. If your facility, if at your end, you're not the one that does that, the appropriate people have to recommend or allow the people to go for the scans so that they could check all this out. So yesterday, a client sent me her scan. She said she was really worried because her scan shows that she has an extra lobe. We call it subcentrate placenta, okay? So I was telling her, oh, it's not anything that you should be worried about, okay? Although it is rare, some people have subcentrate placentas, and it is good that the scan has found it. So I told her what she should do, which is when she's in labor, she should just remind her attendant, the person attending to her, that, oh, please look at this scan for me. Maybe not to make it look like she's too known so that she doesn't get that kind of feedback she doesn't want to get. She could just ask that, oh, please, does it mean that something is wrong with the placenta, so that it will bring the care providers attention to taking good care, or when it gets to the time of delivering placenta, the care provider would be more conscious and know that she has to take 2 placentas out, okay, and not 1. So it's very important we take closer look at the ultrasound scans even before we conduct deliveries on our pregnant women. It informs us. So even I told her that even if she has to go for a C-section, she should just, I know that her surgeon would be reminded, okay, that there's an extra lobe, so that they will remove it, else she will bleed. So it's very, very important we take our ultrasound scans, very important, okay? We should be serious with it. Now we'll be talking about treatment and prevention. During pregnancy, most pregnant women, it's not most, every pregnant woman is given iron supplements. I know people that call me, they're like, oh, midwife, me when I take, I vomit. Yes, some people have allergies. Some people just don't like the smell of some iron supplements, okay? However, they have to take iron supplements, okay? Because now the blood supply is for both people, even sometimes 2 or 3, because the mother could be carrying twins, could be carrying triplets. So the woman has to boost her blood so that the babies would be nourished well, okay? Now, so you should let them know that when they take iron supplements, they will have some normal side effects like dark stools, okay? Someone will take an iron supplement and say, hey, my poo-poo has become black. The person's mind might not even go there. But when you let them know that, okay, when you take an iron supplement, you could have dark stools. Some people could vomit. Some people, those are the normal things, okay? Unless the person is allergic to a particular iron supplement, then you give another one because there are lots of iron supplements, okay? Then we also give them anti-malaria medications, which I said this is PD people shouldn't take, okay? So anti-malaria medication is given mostly after you felt baby's movement, okay? For someone that is the person's first pregnancy, they tend to feel baby's movement after 16 weeks, after 20 weeks, some people even 20 weeks before they feel the movement. But if someone is in, maybe this is your 3rd, 2nd pregnancy, for such people, they tend to feel baby's movements from 16 weeks, okay? What happens with the first-time moms is they are not able to identify the movement well. They don't know if, is it baby's movement I'm feeling? They are not able to identify. Okay, so that's what causes that, okay? Now, if you start feeling baby's movement, you are not just GSSPD deficient, you would be given anti-malaria. And you should encourage them that they should eat before they take the anti-malaria medication. You know, every malaria medication has an effect. You will take it and you'll feel drowsy, you will take it, you'll feel very tired. So when you eat before you take it, it makes you stronger before, like, while you take it, okay? So let's take note of that. Now, ITN is insecticide-treated net. Most facilities give insecticide-treated net immediately, like during your booking visit, okay? Most facilities give that. I don't know how you do it at Kenya, maybe you could share it with us, but in Ghana, most facilities give clients insecticide-treated net during their first visit, okay? Then that is to prevent malaria, because malaria is killing lots of pregnant women than we think. And because a lot of people are not there's no statistics, they are just dying silently. We are not talking about it. Now everyone is talking about COVID. I think COVID has come down a little bit. That is that with insecticide treated nets, okay? Then we'll be talking about tetanus immunization. So tetanus is very important, okay? It prevents baby against whooping cough. Now, someone will say, oh, I've taken tetanus already. I took it before I got pregnant. Is there any that I take it during pregnancy? Yes, please. So if you've taken all the tetanus dose before, which is the first dose, you're supposed to take the first dose, like the time you take it, then you take the second dose. It's up to 5 doses, okay? Now, if you've taken them, you might not even finish your 5th dose. But if you've taken any tetanus vaccine before or immunization before, when you're pregnant, you have to take again, okay? Which would protect your baby. So it's very important they are giving tetanus immunization. So let's move to health education. This is big, like this is very, very important, okay? And this health education, okay, so I'm going to just talk about how we do it here in Ghana. When I finish, maybe someone will just bring my attention to what you people do at Kenya too, okay? Please feel free. So in Ghana, all these topics are like they have schedules, okay? Some, depending on your healthcare provider, the person could decide that, oh, okay, when you come, I'll share 2 with you. When you go and come back again, I'll share another 2 with you. Then I'll share 3 with you. Like they would just plan how they want to do it. So you need to talk extensively to the client about nutrition. I hear a lot of pregnant women ask, what do you want us to eat? Because I always say eat well. So they ask, midwife, like, what do you really want us to eat? And I'm like, I'm just saying eat well. Now, eat well is a big word. Eating well means that they have to eat foods that have more leafy vegetables, eat foods that have more fiber, drink enough water, and make sure that they are not hungry. Some people tend to skip their meals because they are like, oh, I'm not hungry. But you should tell them that their babies depend on what they eat, okay? What they eat is what is transferred to their baby. So they have to eat well so that their babies could be well nourished and grow well throughout their pregnancy. I think I can see a question here, so let me just look at it. Please, I know taking all the 5 shots protect you for life. What if a pregnant woman has taken all the 5 shots before pregnancy? Should she still be vaccinated? Okay, so yes, because I've received this question and I researched on it, then what I found was you should take at least 1 during your pregnancy. So that is it, okay? Even if you've taken all the 5 shots, which is, so the first one, you're taking it, when you take the first one, you take the second one 4 weeks after you've taken the first one, and the third one, 6 months after you've taken the second one, 4th one, between 1 to 5 years after you've taken the 3rd one, then the 5th one, 1 to 10 years. But I learned it's true that the 5th shot protects you for life, but I learned if you get pregnant again, you're supposed to take at least 1 shot during pregnancy. So maybe you could share other thoughts with us, okay?
Yeah.
Anyone saying something, please? Hello. Hello.
Yes, we can hear you.
Okay, so please, I'll continue with rest and sleep. So it's very important you educate your client on rest and sleep. Every pregnant woman has to sleep well, okay? When they sleep well, they'll wake up more refreshed. Most people attribute, hello.
Okay, kindly, okay, I guess you can unmute everyone. Okay, you can mute everyone so that we don't hear the background noises from those who have not muted themselves.
Okay, thank you.
Since I'm not the, you are now the host since I left the other time and then I came back now, I'm not a host. Yeah.
Okay. Okay, so let's continue. So I was talking about rest and sleep. So it's very, very important they sleep, especially at night. They should try and sleep 8 hours or more, okay? Especially, when pregnancy advances, most pregnant women have one of the biggest challenge, which is difficulty in sleeping, okay? So you tell them to exercise, especially in the evening, which would help them to be able to be quite tired before they sleep. Now, when you're a bit tired, you're able to sleep well, okay? So we should just encourage them to have a little exercise, which would help them to sleep well at night. Then we talk about personal hygiene. So that's why when they come, we are looking at them physical, like we are doing head to toe examination. So while you do that, after you do that, you talk to them about their personal hygiene, how they should care for their hair, their nails, how that they have to wear their brassiere always, how that they have to dress well. Some people think, oh, if you're pregnant, you can just be anyhow. Like some people don't really consider their personal hygiene when they are pregnant, but the care provider has to draw their attention to it, okay? So that they take good care of themselves, how that they would have to bath at least 2 times. Then we start education, we start talking about family planning during pregnancy so that clients don't give birth and get pregnant again. So I think one of my clients, she gave birth last year. 2 days ago, she just WhatsApped me, oh, midwife, I'm pregnant again. And I'd told them about family planning. I told them a lot of things. So just imagine someone that has been informed about family planning and has still gotten pregnant some months after giving birth. How much more someone that has not been informed? So it's very, very important to start family planning education from the time of pregnancy. Okay, then we talk about immunization. That's when we are talking about the tetanus injections, okay? Then let's talk about danger signs in pregnancy. There was this client I had, I don't know if we finish this section, you could freely visit my page on Facebook. There's this story, one of my clients, she WhatsApped me that her face was swollen. Immediately, I heard my face is swollen. I told her, my dear, please go to the hospital. There's someone carrying twins and with swollen face, hands and feet. It's a danger sign in pregnancy. So we have to know the danger signs in pregnancy so that if they come with any of them, we'll be able to help them. Okay, so there are lots of danger signs. Bleeding, any kind of blood, if it's a dot, if it's spot, whatever it is, so far as it is blood, it's a danger sign. Dizziness, blurred vision, they are all danger signs. If the person is not feeling baby's movement, the person should come to the hospital. Let them feel comfortable to always come around if they need help. Okay, then we talk to them about sexually transmitted infections, that's HIV, and other sexually transmitted infections. Okay, so while we talk to them about sexually transmitted infections, let's talk to them about sex. I made a post, I think, a friend interviewed me about sex during pregnancy. And lots of people feel they shouldn't have sex when they are pregnant. But it's only few people that would be told not to have sex because they might have some complications. Okay, so you let them know that, oh, if your scan is fine, you've not had any you've not had any miscarriage spontaneously before, you've not had any issue with your placenta, like in this recent pregnancy, if everything is fine with you from your labs and our physical examination, you should have sex and educate them on the sex positions they should try while they are pregnant, because at every stage of pregnancy, there will be an appropriate sex position for them. So please, let's not shy away from discussions like this. Let's engage them, okay? Then we'll talk to them about birth preparedness and complication readiness. I've met a lot of people who say, oh, midwife, me, no, I want to give birth by myself. I don't want to have a cesarean section. So such a person, if the person has to be given a cesarean section, the person will not go. If the person has to go through a cesarean section, the person will not agree, because the person has a pre-informed mind that I must have a vaginal delivery. But if you let the client know that, please, can you unmute? Can you mute yourself? I'm trying to mute them. Okay, so let's continue. So talking about birth preparedness, so I was talking about people that decide that they have to have vaginal deliveries, okay? But when they go into labor and their complications, they are not ready to accept that, okay, there's a complication and I would have to now go for a C-section. Please, it's very, very important that we let our clients know that there are a lot of things that can change your labor into a C-section. Like you are in labor and we realize that after membranes have been ruptured, it is the cord that is coming. If it is the cord that is presenting, you will not have a vaginal delivery. If your labor is not progressing well, you're having an obstructed labor, you will not have a vaginal delivery. Let them be prepared for both vaginal delivery and C-sections, so that whatever comes their way, they'll gladly accept. Okay, so please, that's about birth preparedness and complication readiness. Let them buy their items. Give them the list they need to buy the items, like the list they have to look on, which we call LIET. Let them look on that. Give it to them early, so that they could be buying the things little by little, so that by the time they would be able to get all that they need. Then we also talk to them about prevention of malaria. As we said, we would be giving some of them the anti-malaria medication. Then we said we are giving them to the treated nets. So we should talk to them again that if it's evening, they should close their doors. They should close their louver blades if it's not having nets. They should get nets. They should sleep under the treated nets we've given them. You know, some people take the treated net and don't sleep under it because they say, oh, there's too much heat in it. But why are we giving it to you if you will not use it? Have you seen? So please, let us talk to them about malaria and how that it has killed a lot of pregnant women. Then finally, on my chat and on my notes, we are talking to them about how they monitor their baby's movement, which is very important. There are people that, so I still about Facebook. Last year, one of my clients lost her baby. Okay, so actually, as for her, it's as a result of a condition still about birth preparedness. She didn't want to go for a C-section, wanted a vaginal delivery at all costs, and lost her baby. Okay, for monitoring baby's movement, you need to keep an eye on your baby. If the day ends and you've not felt your baby move, you shouldn't be happy about it, because when the day began, you've not been sitting at one place. That's the same way your baby is. Mostly, we treat our babies like they are robots, but the babies are not robots, okay? So please, they are human beings like you. Some people's babies move very, like in the morning, other babies move at night. Know what happens to your baby. So this is what you are telling the client. They should know what happens to their babies. With them, everyone is unique. So depending on the time your baby is more active, take note of it. If that time comes and baby is not active, ask yourself, have I eaten? Have I drunk enough water? Like, then rub your hands on your abdomen. Oh, baby, it's been long. Mommy has missed you. Those are the things you do for baby to cake. You could turn a torch light on and put on your abdomen. Talk to your babies because they listen to you, okay? You can also play loud songs, loud music, and put on your abdomen, maybe on your phone, and you just put on your abdomen. When you do that, it helps your baby to, your baby should move after all of that. If you've done all of that and baby is not moving, please go to the nearest hospital. You just go and tell them, oh, I've not felt my baby's movement today and I'm quite worried. They'll check the heartbeat, then you can sleep. So please, let's take note of that, okay? So depending on the facility you go to, they'll talk to you about other things, okay, that are of importance to them, okay? They will talk to you about what to expect when you are going into labor, how C-section is done, how you should, how you should behave when you are in labor. I know people that don't know that, oh, if I'm in pain or if the contractions come, I have to do deep breathing exercises. All of that has to be taught during pregnancy, okay? So it's very, very important we teach our women all of this. Now let's go to our next slide. Okay, so we'll be talking about benefits of good antenatal care. Now, high quality maternal health, so that's the benefit, okay? The mother would have a high quality health, which will lead to reduced maternal mortality and morbidity. So when the mother is having good health, the mother will not fall sick and the mother will not die. It would reduce perinatal mortality, that is neonatal death in the first week of life. You know, if pregnancy has not been well managed or someone has not gone through pregnancy well, they could give birth, but baby could die within the first week of life, which is perinatal mortality, okay? So good antenatal care prevents that or reduces it, okay? Then there are lower risk of preterm deliveries because the woman knows the danger signs. The woman is well informed now. It helps with the general health and hygiene of the mother throughout the pregnancy, okay? And it improves the economy of the country. You know, if the woman is well educated and informed, it helps her to live a very healthy life, okay? And we are able to diagnose abnormalities, as we talked about, that we are checking our parameters so well. We are very conscious of what we get from everything we do for our pregnant women, be it vital signs, be it the scan, be it our head-to-toe examination. So we are able to identify abnormalities, diagnose and identify them, okay? Then it would help to reduce complications in labor, such as malpresentation, because we have seen it from the ultrasound scan, okay? Then it would also promote good relationships between the client and the caregivers so that the client can share her problems and interests, which is very key. Okay, let's quickly just go to focused antenatal care. I think our time is almost fast spent. I want to quickly catch up so that we can ask our questions, although we are just some minutes away. Please, if you have questions, you can raise your hand or you can just put it in our chat so that we talk about it, okay? So now we are talking about focused antenatal care. Please, do you, okay, so let me just, I don't know if you do it at your end, but we do it here in Ghana, okay? So focused antenatal care is an individualized, client-centered, comprehensive antenatal care that emphasizes on disease detection and not classification of risk. Please, are you with me? Hello?
Yes, we'll get.
Okay, so do you do focus antenatal at your end? Like in Ghana, one midwife or one doctor has to attend to a specific client throughout pregnancy. Okay, that's focus antenatal. You are seeing that person every time the person comes. So then the client knows her nurse or her midwife. The midwife knows her client, knows the people that will come this week, knows the people that will come next week. That's focus antenatal. Please, do you do some at Kenya?
Antenatal.
Please, do you do focus antenatal at Kenya?
Yes.
Okay, is it like the way I'm saying it?
Yeah, it is. But
Okay.
now do it depending on the schedule you have. Like the next mother will be doing, because they come with 4 visits. So okay.
Please, your line was breaking, so I didn't get you well.
Yeah, we actually do the focused antenatal care. It does happen.
Okay.
Okay.
But I heard you say some 4 visits. You know, the 4 visits is for someone that has a normal labor, a normal pregnancy. Okay. So if the pregnancy is, we've identified any abnormality, it means the person will come more than the 4 visits. Okay, so now let's go. Okay. Now what's the aim of focused antenatal? We want to focus on giving individualized care. Okay. You know, those days, they just gather all the pregnant women and talk to them about general stuffs and just leave them, and they just hurry up and they go home. Like, it makes the clinic very short, okay? But now we are doing focus antenatal because we want to be focused and give everyone an individualized care, because everyone's challenge is different from another person's own. Like, everyone has a different challenge, which will make a client-centered. Okay, so the client will feel very appreciated, feel so loved because the midwife has time with her, okay? And there are fewer but comprehensive visits. Because anytime the client comes, the midwife is able to pour more into the client. The midwife is able to explain a lot of things to the client, okay? And it is focused on early detection of disease and management. You know, for focus antenatal, because the person has been coming to one midwife, that's why the reception is very important. How you've done your introduction for the first time that the client came. So that will inform the client that, oh, this midwife is a nice person. I can talk to her about my challenge. I can talk to her about my fears. So it would help you to detect diseases and manage them early, because you are treating the person as an individual person, okay? So when you do your palpations, you check the scans, you are asking relevant questions, it would help you to detect any disease. Most especially, you are observing, okay? So while you observe, oh, this client, are you okay? Is this happening to you? Then it helps you to detect and manage any kind of disease the woman might have brought, okay? Then it also encourages male involvement. It's very important we involve the male in pregnancy. Okay, so focus antenatal really helps the men to follow their partners, because they know that, oh, in this room, my partner and I can go. Unlike those days that they are all just seated and everyone is just talking to like the midwife just talks to all of them generally. I remembered when I was at the whole teaching hospital, we do it in a way that when you come with your partner, you go earlier. Would you imagine? So people really had issues with pregnant women that come with their partners because they are like, we are all in a hurry. How come you have come and all in the name of you've come with your partner? And the excuses they make, some of the excuses they make are, oh, my partner is going to work. So when they make such excuses, the midwives attend to them earlier. So male involvement is very, very important. Focus Antenatal encourages that. Now, so we'll talk about some benefits of focused antenatal. And focused antenatal ensures privacy. Your privacy and confidentiality is assured, okay? Because you and your partner are going into one room to see one midwife. If a student is there, fine. If another midwife is there, fine. But because it's one-on-one, the client knows that, oh, okay, there's privacy here. I can freely express my mind here. I can freely tell them what it's bothering me here, okay? So confidentiality is assured. Please, it's very important we keep our clients' issues to ourselves in between, like it should be between the two of us, okay? So that the clients can confidently say that, okay, as for my midwife, what I'm sharing with her, she will not tell anyone. It would help them to open up to you more, okay? So the next one says, it's continuity of care is provided by the same provider, which is very true, okay? Because the person was the same person that attended to you, the person will not even struggle to know what has been happening to you over the weeks. So when you meet a client today, the next time you meet the client, you'll remember that, oh, okay, she was the one that I told to drink enough water because her urine had protein and glucose. She was the one that I told to eat well because her weight wasn't encouraging. So it helps the care provider and the client to have that nice time together, okay? And the client will be able to, the care provider will be able to assess the client well, okay? Then it also improves partner or support person involvement, as we talked about earlier, okay? Attendance is increased, which is so important. I've realized, and it's so true, I don't know if the same thing is happening in Kenya, but in Ghana, antenatal care attendance has improved. Like, there's a little improvement for now because it's better than before, because they have adolescent corner, like a place for adolescents, so that they don't feel like, oh, okay, I'm an adolescent and I'm pregnant and I feel shy, I'm among elderly people, okay? So we have an adolescent corner, we have time, one-on-one time with the clients, which have increased attendance. Then there's improved quality care, which is so true. Because if the care had not been quality, the people will not be coming. Okay, so focus antenatal helps to improve quality care. Then education and counseling is based on the need of the client, which is so true. When they know what the client needs, when the care provider knows what is most important for the client, the care provider goes all out to give the client that. Okay, so it's very, it's been very beneficial, okay? Then it also improves client interaction with provider, which is still about our introduction, okay? So the client would be able to open up to the provider. The client would be able to tell the provider any concern because trust has been developed, which is the last point. Focused antenatal develops trust between clients and providers. So the provider would trust the client would trust the provider that, oh, if I tell my care provider this, it would be beneficial. So a colleague told us the other time that her client opened up to her at her workplace. She works in another facility. So the client opened up to her that, so what happened is that anytime the woman comes for antenatal, it's like her eyes are quite a bit bigger when she comes and it looks quite red. So she was like, oh, what is happening to you? Because it's focused antenatal. She was like, oh, are you okay? Is everything okay at home? Is everything fine? Then the woman was like, oh, everything is fine. It's just that my husband beat me yesterday. So it made me very sad. You know, the client might not have opened up so much to the midwife if the midwife wasn't nice or she has not developed a trust on or has not trusted that midwife. So when the client opened up to her, she really advised her and told the client to invite her husband for antenatal like the next time. So when the husband came, my colleague didn't behave as though she has heard anything from the wife. She just said, oh, during pregnancy, women do some things that might annoy you, but you need to just be patient with them and know that they are humans and it's the condition that is making them behave the way they behave. And she even used the opportunity to talk to the client's partner to help her with house chores and other things, which has helped them. So when clients trust their providers, it makes them to freely open up to them. So it's very, very important we build a trusting relationship between our clients and ourselves, okay? So this is the end of our slide. This is the reference. Thank you. If you have any questions, please feel free and ask. So now the floor is opened. Hello, hello, hello.
Oh, thank you so much, Adzo, for the session, for the slides, and for the whole interactive session, for the whole interactive discussion. It has been a fruitful one. I don't know if you answered this question. It was posted on the chats.
Which one, please?
Please, I know taking all 5 shots protects one for life. What if a pregnant woman have taken all 5 shots before pregnancy? Should she still be vaccinated? I think she was talking about the tetanus vaccine.
Yes, and I answered it that I knew that when you've taken all the 5 shots, it protects you for life, which is so true, okay? But I read elsewhere that when you are pregnant, you need to take again because the time you took it, you were not pregnant. So now that you are pregnant, you should take again only once for your baby. That was what I read. So if maybe we can go and read more on that and know if it is really true that you are protected for life, because that was what I read. Thank you.
Thank you. I also had the same information, like when you already have the tetanus vaccine for the first for 5 shots, when you get pregnant, you are going to get another shot for to protect your baby. I think that was the same information that I also heard from somewhere.
Yes, please. That was what I read. That's what I read.
Yeah. Okay. So thank you everyone for joining. Thank you so much, midwife. We hope to interact more with you. If there will be any question or any interactive session, any arising matters, I will inform you. And for the members, if you have any question, you can inbox me, Mercy Kiptele. Everyone has my number, and also Katile. Yeah, and the notes, I will share them in the Google Classroom for everyone to get to access them and learn more. Yeah, thank you so much. You can all have a blessed night and live at your own pleasure.
Okay. Good night. Good night.
Good night too.